I'm Tamara Thomas, editor-in-chief of UrbanHealthToday.com, part of the DocWire family of medical news sites, and I want to thank you for tuning in to Urban Health Weekly. Our goal each week is to keep you informed of the latest in health and medical news right from today's headlines. It's time to empower yourself with open conversations about your medical care with news that matters to you. So are you ready? Let's get started. Hi, I'm Tamara Thomas, and welcome to Urban Health Weekly, where we talk about medical news and health topics that matter to you. So I'm here with Jackie and Lou. How are you guys?
Good. How are you guys doing?
Doing great.
Well, I'm glad all you are. And, I had an interesting, remember I said that I was going to have an interview talking about cultural sensitivity? Well,
yeah.
So I had a talk with a Dr. Jessica Shepard, and we'll get into that later. But first, I want to talk about Medicare. And that's going to be our medical news of the week. So Medicare Advantage plans deny needed care that should be covered to tens of thousands of people a year, federal investigators have found. That's terrible. Federal investigators urge Medicare officials to strengthen oversight of these private insurance plans, which provide benefits to 28 million older Americans, and call for increased enforcement against plans with a pattern of inappropriate denials. Oh my gosh, that reminds me of what happens. This managed care thing where they're doing has been such hell. I remember my mom had managed care.
So wait, she had Medicare and then they outsourced it to a managed care? Is that how it worked?
Correct. And
so
what happened?
Like a private company was running.
A private company was getting those dollars and deciding what to do with
those
dollars.
Okay.
And so what was happening was they were denying everything. Now,
It's Medicaid, yeah.
So at one point, it's all the same
it's
pot,
all the same, yeah.
Really. I mean, So in any event, what happened was they wouldn't pay for anything. She was an invalid. She couldn't feed herself. She couldn't dress herself. She couldn't walk. She couldn't nothing. And I kept explaining to them, like, she needs 8 hours of care. She needs 8 hours of home care. And they're like, well, we can only give her 4 hours of home. 4 hours. What is that supposed to do? Like, I have to work. I can't take care of her. Like, this plan is supposed to pay for. She needs full care. And they just wouldn't. So I finally.
And you needed to work like full time to make sure she got her care.
Right. And so what happened was I finally had to go, I had to appeal because they just kept denying. And I had to appeal and I had to have them removed from, I don't know if they can do that anymore. They probably changed the law since then. This was like 2009. But at the time, I had to petition to have them removed as the managed care and just have it straight Medicaid.
Really? So do you think that was that like a seasonal thing? Like now with Health Marketplace, you have like a time of year where you can change up. Do you think then did they have that then where you had to wait until, like, let's say January before you could?
No, this was before all of that. They didn't have that back then, not to my knowledge. I don't think they had that back then, no.
Okay.
Well, you see, and
you've got aging parents. Did they have that back then?
It's changed, but with the advent of more and more people now selecting Medicaid and Medicare, one of the first, and again, let me just backtrack a little bit. A lot of people, there's a whole thing of Medicaid and Medicare for all, which in concept sounds good. But there's the concept and then there's the reality. And the reality is pretty grim because you're almost in a worse situation than you are starting out. And let me explain what happens. When one goes on Medicaid, you would think like the government pays all of this and the government regulates it. The government does not have the capabilities, the people, any of that to sit down and manage your health. They just don't do it. The government, the US government's not going to say, yeah, you can get the colonoscopy, or no, you cannot get the colonoscopy. Yes, you're entitled to a health aid, or no, you're not. What happens is when you
They
go on
farm this out
Medicaid,
to the insurance
no,
companies.
you pick one. You pick one. So you pick AgeWell, you pick Fidelis. You try to pick one that kind of fits.
I don't know if she actually picked. I think one was just kind of assigned.
Well,
Well, if you don't pick one,
they
if you
had
don't
it
pick
assigned.
one, one is assigned to you.
Mhm.
So, and that's why an educated consumer is a good thing, because you should start saying, okay, you know, which one of these companies, which one of these insurance companies, and
Well, I think
gonna
it's
pick
more
one?
part of the lexicon now, but I think back then people just assumed that.
People just assume they got it, and they
Yeah.
said, all right, pick one for me. You know, now it's like, well, wait a minute, this one doesn't
You
have
just
a very
kind of get
good.
the letter in the mail, and then it's
Still
like,
hard to pick those out though, because it's still like, it's still confusing. And unless you're like really informed in that kind of like language, it's
Yes.
hard.
yes.
Yeah, I had to ask around for people that had experienced it, had aging parents and all that. And the first one I picked was pretty bad. The second one has been okay. I'm not going to say it's great. Then these companies, they become like your insurance company. The payer is Medicaid. Those are the people that pay the bills to them. But they become the administrators. They become the providers and all that.
gatekeeper.
The gatekeeper.
Gatekeeper.
And you know, these companies have a profit incentive.
Yes.
So you have
they
to
try
be
to keep as
very-
much money as they can and
Right.
pay out as little as possible. But the bill still
Exactly.
stays the same as far as the government is concerned. They're still paying that same amount. It's just not trickling down to the patient level.
Right. So, and it becomes even more expensive because now not only are you paying for these costs, but at the end of the day, what you're doing is you're paying for this whole level of administration that you hope is doing, and by you the patient and you the government, if both of yous are I know my cousin
But
Vinny. I'm channeling
New Yorkese.
Use guys.
channeling the movie my
My
cousin
Vinny.
Vinny.
Mhm.
So
Use
anyway,
guys.
yeah, you know, both parties kind of rely on this to be a fair thing, but no, there's a profit incentive here. That's what I was trying to get at through all of that. There is an incentive for these insurance companies that kind of manage these cares to deny or not deny, or to provide the cheapest possible alternative. And it's not always a good thing.
Well, I've been following the story of this one individual that infuriated me, speaking of all of this. It's the story of Shane Bear from North Carolina. He's a guy in a wheelchair. Have you heard this story?
Vaguely.
Okay, so he was in a car accident and he ended up in a wheelchair. And then, you know, just when he got acclimated to that life, he developed a condition called CIDP, which is chronic inflammatory demyelinating polyradicular neuropathy, which is it's a rare autoimmune disorder that basically shuts down the nerve endings and causes muscle weakness and eventual paralysis. So he's been taking this drug called Hizentra to keep the disease at bay, because if he loses the use of his hands, his arms, he's basically going to become an invalid because he's not going to be able to even operate his wheelchair.
Oh.
So what happened was Medicaid had denied the coverage of the drug, and he had appealed. And he had appealed 5 times and lost 5 times until the judge finally said, okay, you've got to cover this under your Part D. So Medicare took the L, then went back to the books and changed the rules and switched it from Part D to Part B, thereby not covering it again. Do you see what I'm saying?
Wow, a bait and switch.
Because of that, right. So at least because of that technical language where the judge said, look, you've got to cover this under Part D, they use that as their little squiggle out of get out of jail free card and switched it to Part B. So then what he did was he tried to play within the rules, and he started taking another drug called Zembify. And again, he started, and part of the reason he needs this medication is because, you know, he doesn't want to have to go to the hospital all the time and get an infusion. It's something that he can take at home.
Right.
So he switched from the Hizentra to Zembify. Like, he's trying to work within
Yes.
the system, and they denied him again.
Oh my God.
And again and again. And so finally he had to get the press on his side, the local press. So WBTV did an investigation to find out why Medicare has denied his appeal. And they quickly reversed, and now he's able to get,
Oh, they shamed them.
yes. But if they were so easily shamed,
Why didn't they do it? Clearly,
Why
they knew
didn't
they
they
were in the
do it?
wrong. Some bean counter.
with exactly.
Wow.
Yeah. Yeah. So his plan sponsors from the Centers for Medicare and Medicaid Services had just been denying his appeals over and over and over and over and over. And this poor man has just been through the ringer, not knowing what his future holds, because these drugs could potentially cost him tens of thousands of dollars a month that I don't know if he has or not. And even if he does have it, who wants to spend? If you have insurance, why do you need to spend $10,000 a month for medication that you clearly need?
Right.
So kudos to his team.
And this is, yeah, absolutely. And the use of his hands.
Yes.
Then he need, you gotta have that. I remember this veteran who had lost his hands and his feet in the Gulf War, and he was talking about not being able to use your legs was really hard, but nothing was as hard as not being able to use your hands. And
Yes.
so that would be denying this guy a preventable.
Exactly.
I
That
mean,
would be denying him his humanity and his independence.
right. God.
I mean, and he'd already lost so much, and then they
Right.
wanted to, in some bean counters, want to deny him, his humanity, which is just deplorable. And this is the same government who likes to try to shame every private business known to mankind. And yet here they are allowing this kind of stuff to happen. It's absolutely disgusting.
Not cracking down on this managed care like this.
No, exactly. It's disgusting.
Yeah. Agreed. Agreed. I know everybody's waiting for a more profound,
But
thing, but I think
Right.
disgusting is the best way to call it. And let's all realize that, the secondary medicine and stuff that they give you is usually not as effective. You're going on tertiary.
Oh,
They're subjecting you to 20-year-old technology or whatever, because these drugs they're generics now, but they're at least 13 years old, because that's how long your average drug takes to become a generic. So they are giving you a lot of stuff that you're being basically treated with technology that was 20 to 30 years old. And if you think things don't move forward, just think of using a cell phone, if they even existed from 20, 30 years ago. We just found one. I just found one the other day, and one of my old Sprint ones with the little keyboard and all that.
You had Sprint.
wow.
I had Sprint.
Mr. Big Executive, you didn't have Verizon all of these years.
Yeah, well, I had one of those phones like they had in the movie Wall Street, where it's about the shoebox that you put to your head, But if you're taking medication from those days, then the outcomes are going to be based on the science and the stuff that was back then.
Have you heard of this drug Zembify or Hizentra? Have you
No,
heard
I
of
haven't
them?
heard from it. But what they do is they push you down the chain to get you to take a generic or something like that. There's nothing wrong with generics in certain instances, but in many, many diseases, there's something better.
Yeah.
I mean, these drugs, they get approved because they're supposedly better than their predecessor. So if you go 4 or 5 generations down, you're not going to get the effective cures that you're supposed to be getting.
Well, this is not a cure. This is just to prevent him from
Treatment from getting worse, I suppose.
from getting worse and
Okay,
and him, declining.
Exactly.
But yeah, for him not to be able to use his hands, that's it. He's done. He's done. And I shame on you, government. Anyway.
That's
so
this show. Shame on you.
Shame on you.
Shame.
Shame on you, Medicaid. People who really need these services are not getting coverage, and it's just deplorable. And I think they really need to look internally and fix this, because people are spending a lot of money. Like people if you've been working for a long time, you've been paying into the system a very long time. And then to have the system turn around and say to you, well, we're not going to pay for this and we're not going to pay for that. That's unconscionable. Anyway, just shame on you. So on to this week's topic, managing cultural differences in healthcare. Culture is a complex concept. It includes people's beliefs, values, behaviors, and ways of understanding their world. In medicine, managing cultural differences, including customs, is essential to providing high-quality healthcare. One challenge is that patients may not realize they have customs that could jeopardize their wellness. Culture is largely invisible to people who share it, but to outsiders, the customs and ways of life of different cultures are often obvious and sometimes strange. So the writer gives a few examples from his own experience. I'm in Japan for a conference and I arrive at the house of my host. I knock on the door and they open it, greet me with short bows and smiles, and invite me into the entry area. We stand and exchange pleasantries for quite a while. Eventually, it seems to me we should be making our way into the living room, but for some reason we aren't. I notice people glance at my feet occasionally and look uncomfortable. It dawns on me that I have my shoes on and everyone else is wearing indoor slippers. How strange to them that I would walk off the street into a house without removing my dirty soled shoes.
Wow.
Yeah. You know, it's funny. I remember I spent time in Germany and I went to visit someone at their home, and he was originally from Japan. He wasn't Japanese, but he's lived in Japan for many, many years. Mm-hmm. And I entered his home. And now I'll tell you, at home, I take my shoes off. I don't.
We do that at our house too. We lose the shoes right away. Yes.
But I'll tell you about my cultural insensitivity. I assumed because that he was European, that he wouldn't care whether I had my shoes on or not. So I proceeded to walk in and I didn't ask, because I always keep a pair of like little socks in my handbag just in case, you know, I can take my shoes off. But it didn't occur to me that this European man would care whether I took my shoes off or not. So we were standing at the door and I'm like, what? And he's like, aren't you going to remove your shoes? And I'm like, oh, of course, yes. And then he starts telling me, he's like, why is it that Americans never want to take their dirty shoes off? It's so filthy to walk around your house. And I'm like, I know what you mean. But that was my bit of cultural insensitivity.
I wouldn't have expected it because, you know, my European relatives, I'm not sure they take I don't know what they do now. I mean, everybody's more.
Right. I assumed because he was European that he wouldn't care whether I took.
Right.
That was interesting. But what is cultural awareness? Cultural awareness is the ability to perceive our own cultural beliefs, values, and customs, and to understand how they shape our decisions and behavior. Cultural awareness requires us to step back and look at ourselves as through a stranger's eyes and to open our minds to different ways of doing things. Margaret Mead described it best when she explained the core value of anthropology: to make the familiar strange and the strange familiar. Cultural awareness on the part of both practitioner and patient is key to identifying cultural barriers to medical care. Culture influences patients' response to illness and treatment. In our multicultural society, different customs can lead to confusion and misunderstanding, which erode trust and patient adherence. Here are 3 examples that show how deeply culture impacts medical care. First one, a patient from Morocco had to be hospitalized for pneumonia. When a doctor arrived at the unit, several nurses, nursing assistants, and the ward clerk were engaged in a loud argument with a group of Moroccan friends and family members. The staff were trying to escort the visitors out of the patient's room, but in Morocco, they wouldn't consider leaving a sick relative alone in the hospital room. The notion of visiting hours, which is so normal for us, was completely foreign to them. Here's number 2. In New York, Orthodox and Hasidic Jewish traditions helped shape their policies and procedures. The hospital had a Sabbath elevator, so no one had to do the work on the holy day. And healthcare professionals and patients were not supposed to make physical contact across gender lines. They had also observed plenty of dietary customs from various cultures: kosher, halal, and vegetarian menus, seaweed soup being served to Korean women after giving birth, and attention paid to the hot and cold properties assigned to various foods in traditional Chinese healthcare. Number 3, One of his most memorable patients was an African-American Jehovah's Witness. She was in her late 70s. One of her heart valves wasn't working, and she needed major cardiac surgery to replace it. She also had a bleeding tendency and would require blood transfusion during the operation. However, Jehovah's Witnesses usually decline transfusions of whole blood or blood components, not due to the perceived risk, but based on interpretation of biblical text. She refused to have the surgery. After a lot of introspection and discussion with her family and religious community, it became clear this really was her fully informed wish, so the medical team respected her decision. So here's a cultural awareness checklist. Communication and ongoing education are essential to promoting cultural awareness and providing culturally sensitive care. As you work to develop cultural awareness for yourself and your patients, use this checklist to make sure you're able to understand and negotiate any cultural differences that may directly impact care. 1, establish clear communication. Make sure you know your patient's preferred method of communicating and arrange professional interpretation if necessary. 2, be aware of nonverbal cues without jumping to conclusions. Nonverbal communication conveys a lot of critical information, but it may differ dramatically across cultures. Don't make any assumptions without knowing the person's customs. 3, ask openly about potentially relevant traditions and customs. This includes exploring potential spiritual/religious practices, dietary considerations, and cultural norms that may be particularly important to the patient's clinical situation. 4, use normalizing statements. A respectful way to ask about sensitive issues like culture or religious customs is first to explain that they are very common. E.g., a lot of my patients have customs or practices that are important for me to know about so I can make sure to give you the best possible care. 5, examine your own biases. We all have unconscious biases and prejudices that impact our relationships with patients. Identifying and understanding these biases helps to control them and is essential to achieving cultural awareness. I think this all sounds very nice, but I'm not sure how decades of beliefs combined with the stress of daily rounds or back-to-back patients is really going to allow time for this kind of growth, because this kind of introspection really requires growth and kind of self-awareness. So I think people can change, but if they don't have to, they won't. Particularly if you're not from like a marginalized or socioeconomically disadvantaged group or background.
Where there's no like direct incentive.
Right, exactly. There's no direct incentive for you to change your behavior or to feel like your behavior requires change. Take the NFL, for example. How long has the Rooney Rule been in effect?
What's the Rooney Rule? What's that?
Okay,
Lewis, if you would be so
I'll
kind.
interject. The Rooney Rule is that whenever you have a head coaching vacancy,
Yes.
the team has to interview at least one African-American candidate for that position.
Okay.
And that may sound well in theory, but recently it's been criticized because it hasn't really led to any change at all. And some of the people that have been interviewed, and rightfully so, have been interviewed feeling that, hey, I was just interviewed to tick a box. No one took me seriously.
Oh.
You know, there wasn't that level of engagement that you would expect from an interview. And the answer is,
these are wealthy old men and they do what they want to do.
Yeah.
So they're going through the motions, but it didn't feel like I was ever really a candidate.
Right, exactly. Because people like to work with people that they're comfortable with. People like to hire people that they're comfortable with. And so what happens is you have a homogenous culture that doesn't change.
Yeah.
So that's what I'm saying is what's going on with, most of these doctors. A lot of doctors are not from low income backgrounds.
Right.
Okay. And I think the biggest cultural bias in medicine, to me, is the appalling number of physicians of color that graduate each year. So Blacks represent like 5.7% and Hispanics represent 4.6% of medical school graduates. Okay. Then you have the numbers of the numbers of students of color admitted to these medical schools, that's an unacceptable number also.
What's
when
that number? Do we know?
I don't know that off the top of my head. I could find out. And when they do make it in, many times they graduate with like so many bills. They can't go into the low paying primary care jobs where they'd be most needed.
Well, that, I'm going to use a real world example that kind of would affect me. Hispanics and people from foreign countries, in many instances, live in an extended family situation where part of, let's call it the American culture, for lack of a better term, would be to, hey, if granny's old, put her in a nursing home.
Yeah, it's more like nuclear and not extended. It's,
right. So if you're, a physician that's advising a caregiver for that, you may say to that relative who's the caregiver, well, it's time to put blah blah in a nursing home. To some folks, you might as well have said it's time to take them and throw them off a cliff at the Grand Canyon.
Wow.
Completely culturally unacceptable. Now, we saw some of that during COVID, when a lot of the elderly, especially in Italy and in Spain, they had tremendous death rates in COVID. Why? Because you had multi-generational families.
In one household, yeah.
One household. You also saw that in the United States, and that's why Hispanics were much more prone to have people dying of COVID within one household, because everybody got it in the same household. And then you saw the nursing home stuff here, which, theoretically those people were safe, but we found out in New York that they weren't safe.
Right.
But let's bring it back to the topic. If you're a physician, you have to somehow probe to see what is cultural. If you're advising a family, for example, how to care with an Alzheimer's patient, you have to probe with that family when you're going over alternatives as to what their preferences are. Because what's going to happen is you might wind up with a very offended patient. You may have a total disconnect with your patient where they just walk out and say, well, I'm not going to do that. And it's much like it's a religious practice. There's a lot of cultural practices in play here.
Yes.
That doctors, need to be mindful of. And you can't turn, you can't, you got to tell your patient the truth, but you can't afford to have your patient turned off completely.
By the way, so that number is 11.3% for Black students and 12.7% for Latin students.
Okay.
And for American Indian or Alaskan Natives, that is 8.5%.
So yeah, not huge numbers.
Right, exactly.
But what happens? I mean, you got 11% in the school, and then all of a sudden it's only 5% of doctors. So something happens between here and there. And I think that here and there is an economic thing. I think people start looking at, oh my God, I've just racked up $200,000 of student loans.
I can't afford to do this anymore.
I can't afford.
Or something's happening in my family, some life event. I've got to.
Right. And I have a responsibility, and my money is going to be affected. Yes.
Exactly. And so what happens is you don't have diversity in look, adults, I don't want to be grim here, but at the end of the day, most adults are not terribly self-aware. So to say like, well, ask yourself, what can I do? Can I do more? These people are doing rounds. These people are seeing back-to-back patients. These people, one time I went to see my doctor, and I couldn't help but notice that his shirt was stained and it was not tucked in properly. And I knew that he was having quite a day.
Right.
He was late, and he was profusely apologetic.
He was harried.
He was harried. Who has time for that kind of self-awareness on a regular, any given regular day? When you're harried and you're seeing back-to-back patients. And I'm not letting them off the hook and saying it's impossible. I'm not sure how realistic that is.
Yeah, and also, look, we see, when we start looking at the numbers, we see that there's an 11% of people that come in and they're accepted into medical school. Then we see that there's only half of those people wind up graduating. Okay, so right there, we got to realize that there's a problem. I think much like the Rooney Rule, we're looking at it and saying, hey, we interviewed them, and what happens? Que
We
sera,
picked them
sera.
up.
They're
Yeah.
saying, hey, we let them into school. We met our quota.
Right.
You know, but what is it? And I'm not talking about just one race or another. I'm talking about, you know, I think there's some economic disparities here.
Right.
And
Because this
what,
happens to Appalachian
Right.
applicants as well.
what has to happen in order for
And low
that
income.
to get that
Mhm.
person to finish, to get to the finish line?
Yeah.
You know, it's not only to have them run the race. There has to be accommodations also made to help that person finish,
Yes.
because there are disparities that that person is facing.
Yes.
And, you know, whether it's you know, in Europe, they pay you a salary while you go to college. Now, I get it that they have a completely different economic system.
Don't get me started on that.
With-
Oh, boy. Yeah.
Yeah. You know, it's sometimes where do those dollars come from?
Student loan debt. What's that in
Yeah.
Europe?
Yeah, but it's not a bad idea. And some of these schools have tremendous endowments. And maybe that's a really great place to start using these endowments for helping people
But you
graduate.
made a point, Lou. You made a
Mhm.
point when we were talking about this earlier in terms of the hiring of the
Mhm.
administrators who hire the people, and that
Mhm.
maybe that. Do you remember what you were saying?
Well,
you were saying
yeah,
that.
what happens is you didn't get a lot of, there was very little change in number one jobs because of this affirmative action
Going back
initiative,
to
the Rooney Rule.
Yes.
Ah,
But there was a tremendous amount of number twos hired that were minority people that were never hired. And now, you know, there was a lot of African-American coaches or Hispanic coaches that got a chance to be an assistant coach because they did impress the powers that be at the interview stage. And, you know, maybe, you know,
was a foot in the door of sorts.
right, it got a foot in the door. So now we're seeing the Rooney Rule 10 years later. And did it cause the affirmative action needed for the number one jobs?
Nah,
No,
son.
nope. But for the number two jobs, yes, it did. Now, how do we get those people to move up from the number two slots to those number one slots? And that's where we are right now. In terms
That we're just being in the system, being with the company and being, you know, having experience, they might
Right.
get moved up.
Right. So we've institutionalized, you know, we have let people get the foot in the door, but it has to be more than just getting their foot in the door. There has to be something beyond that. And that's what we're seeing in the medical schools. We've let the people get their feet in the door. We've ticked that box, so let's check that. What we haven't yet accomplished is helping that person to be
But
successful.
vis-a-vis to the population, would you say
Mm-hmm.
that those numbers are reflective of the US population?
Yeah. Does it reflect? I don't even know what the numbers are for the
Well, the
It doesn't.
admissions
population.
stuff is more reflective. What is not reflective of the US population is the people, the completion rate.
Oh, the graduating.
Right, the graduating rate. So, you know, inputting, yes. And I can tell you right now, like in the NFL, everybody's interviewing. Every job requires an African American to be interviewed. Are African Americans being interviewed? Absolutely. Are they becoming successful at the end of that process? Absolutely not.
But also seeing them sometimes do their job
Mhm.
also helps as well. And that's where you get him. So you were talking
Mhm.
about, you know, impressing them in the interview. I think it's not just that. I think it's also seeing them perform these jobs and
Right.
basically destroying the stereotype that they're not capable of doing these jobs.
Right.
If that's even what they're thinking. I don't know what.
I bet it just opens up a possibility that it never entered their minds before. So that don't you think that just
it's the contact, it's having the contact, and
Right.
seeing
suddenly
like-
you're not blind to people of color.
right, because now you know this person, you've seen them in
Right.
action, you see what they can do, you've seen others like them do it, and it's like well, that's not really true. They actually can do these jobs. And so that barrier has been chipped away, right? And so I think getting back to your medical schools, that there needs to be some awareness that there needs to be some sort of support mechanism to make sure that, look, when I was in school, I had a guidance counselor, and I would talk about all kinds of crazy, not a guidance counselor, sorry, that's high school. I would a student advisor, and I had to see my advisor every week because it was a culture shock for me, and I don't know what I would have done without him, because there was a lot of stuff that I didn't understand, and he helped me see it to the end. But part of the reason that happened is because there were people of color in that department who looked at me and said, she needs support. I'm going to put her with the right person that's going to support her.
Someone knew what they were looking at. They knew how to help.
Right, exactly.
Right.
Okay. Because it wasn't just enough that I was smart and I was there. It's like, how do we make sure that how do we hold this person up to make sure she succeeds, because she's not of this world. I'm, in my family, I'm first generation college grad.
Wow.
And to make sure that I succeeded and saw it through to the end. And that's what I see is not happening in the
there's not enough
medical
role
world.
models that can say, hey, this
There's
is how
not
I
enough,
did it.
exactly.
These are the tricks that let me give you a couple of cues, and it will get better. And I think eventually we're going to get there. It's just that we all want eventually to be now. I think it's going way too slow, and we need the change to happen now, not 2 decades from now.
So, it's one thing to sort of, and I don't want to say ram down people's throats, but to kind of, ram down people's throats. So you need to be more aware, and you need to be aware of your unconscious bias. And, for some people that triggers them, like, they get defensive, because it's like, well, there's nothing wrong with me. What are you talking about? I love all people. I'll never forget that unfortunate podcast. Was it the Journal of American Medical Association, where they came out and said, "There's no such thing as a racist doctor," and then they had to pull that because everyone was like, "Wow!"
The person lost their job.
Whose idea was that? I mean, that's a no-brainer.
That was his and his alone, and he is now gone as a result of that faux pas. But in any event, speaking of medical, when we come back, we're going to have a listen to Dr. Jessica Shepard talk about cultural sensitivity in women's health.
All right.
Great.
Hi, I'm Tamara Thomas, Editor-in-Chief of Urban Health Today, and I'm speaking with Dr. Jessica Shepard, a board-certified OBGYN and Organon Health Partner, as well as the founder and CEO of Sanctum Med and Wellness, a wellness concierge practice. She's here today to talk about cultural sensitivity in women's healthcare. Thank you for joining me today, Dr. Shepard.
Great to be here. Thank you for having me.
All right, let's get started. So what exactly is cultural sensitivity? And what does that look like in the healthcare practice setting?
Yeah, absolutely. Cultural sensitivity really is a very broad topic when we think of other cultures, and what are things that are sensitive to them in the fact of possibly maybe being offensive, but also being sensitive to the things that create a positive atmosphere because time has been taken to understand other people's backgrounds, how they process information, and how they communicate.
Can you give an example?
An example of cultural sensitivity could definitely come from a healthcare provider standpoint. When you see a patient that may look different than you, or come from a community that you may not be familiar with, is taking the time to ask in communication what things they are open to, what things are more relevant to them in a situation of speaking about a healthcare disease state. And then also taking the time to practice active listening. So taking cues, whether that's with body language, with eye contact, and these again are all different ways in building cultural sensitivity with interactions that you have with your patients.
So how has this approach evolved over recent years? And what was the inflection point for more broadly recognizing the need for it in your view?
I think that, over the years, I can think of even when I was training, there wasn't much attention paid to it from an institution standpoint. So now you'll see that a lot of hospitals will have cultural sensitivity training for all employees, no matter what level. So from the C-suite down to people who work in ancillary staff spacing. You'll see that is a good way for people to take the time to at least sit and recognize internally ways that they can improve their communication. And I think that this is probably an inflection point. Most recently, I would say, is when we still see maternal mortality rates that are actually still staggering from a statistics standpoint, because one, we do have the best healthcare in the world, but yet we're still seeing the fact that the US has the highest mortality rate among developed countries. And so when you take a statistic like that and have 700 women who die each year in the US as a result of during pregnancy or postpartum or from delivery complications, in one specific category of women, when we think of Black women, that is staggering, and that's something that needs to be discussed.
So I had a thought. I'm thinking of the average clinician's day where they're seeing multiple patients, right? Because, for example, insurance has made it difficult for you to manage the amount of patients and, a fair wage. And I've seen a lot of doctors, for example, just kind of harried, rushed. How do you make time then to be culturally sensitive when you're under pressure?
Yeah, I think that there are multiple levels to that. One that you brought up significantly from the insurance standpoint or from the hospital administration standpoint is the stress that's put on the providers to give really good healthcare in a short amount of time with a lot of patients. So that model in general is not something that to me is sustainable of positive health outcomes. And so I think it requires from a very top level from insurance companies and them taking ownership in how to let providers give the care that they can in an appropriate amount of time, where then that will change the outcome of what we see in healthcare. And so I think that providers ultimately really do care for their patients and want to give them the best healthcare. They're not just put in situations that allow them to do that in the best way possible. And so, from a provider standpoint, I too have seen, the inability to really take time to communicate with my patients. Even taking out race is just the amount of patients that we have to see. And so, that really, just calling it to what it is, I think that there needs to be some responsibility from the structures that put these templates into place.
Okay, so let's talk about stigma. How can stigma impact health outcomes?
Yeah, stigma can impact health outcomes because, again, stigma is what we would see with how that can form some implicit bias. And so all of us have forms of implicit bias, but it really is taking the implicit bias and deciding what do we do with that. And then from a stigma standpoint, the stigma gives us the implicit bias on what we assume that's going on with a patient, how we choose to communicate with that patient. And so that then becomes a significant contributor to health inequities and the social determinant of health.
In your experience, have you found that the need for cultural sensitivity is greater among physicians, or is it equally spread around amongst NPs and PAs as well?
I think that it really is something that is not just for physicians. I think this can even come in office setting of people who receive patients, as far as like their interaction from the time that they have their intake at the front desk to providers to nursing. I think it's what we call the Swiss cheese effect. You may have your healthcare providers have all the cultural sensitivity skills and have if we were to have a utopia of no implicit bias, then you still have moments of patients having some interaction with healthcare. And if that need is not met there, then you still do have a point at which a patient has a bad interaction. And so it really needs to be something that's addressed on a wide scale level.
So one popular implicit bias that I have heard about is the idea that people of color are sort of impervious to pain.
Mhm.
So I wonder how subconscious or how prevalent that idea is among providers in terms of.
That is a great question. I was unaware of that until it was brought to my attention. But after seeing the research behind it, again, because that's something that never was apparent to me because that didn't make sense to me. So I never really thought of it in that light. But now I can see if it's something that one historically has been taught to some degree, then yes, there is an issue with that, because then that then goes to a level of how that's taught from even med school, right? And so from training. And so these are kind of like the, I guess you could say, a microaggression that can be taught throughout training into residency. And then that becomes a part of someone's idea of how pain is perceived or tolerated by a certain group. And so I think I always feel that the best way to address an issue is really go to the fundamentals and the foundation of where that started. And so if we are seeing it in literature and somehow it's being, for lack of a better term, taught, then that's where we need to unravel. Because if we do it to the level of fast forward when people are already well in their career, it's much harder to actually unravel at that point. So we do need to take the steps in when people are training, how that can be something that is completely not part of how someone perceives a group and how they perceive and tolerate pain. Yeah, I think we need to actually do a better job at pain perception in general across the board, because we can even see that in the opioid epidemic, is because there was, no matter what level of pain you have, there's something to block the pain.
Right.
And so if you look from an Eastern philosophy of pain, not all pain is bad, right? It's our body's way of a response in telling us something's going on. What we have done a disservice in is helping people understand pain levels, and how to deal with pain without necessarily having to take pain medication. So clearly we have an issue with pain itself. So how do we address that as well?
So what women's health conditions are you seeing go undiagnosed or misdiagnosed as a result of disparities? And how can HCPs help to bridge this gap?
I think that there are multiple levels of conditions and diseases that are missed. Now that can be for various reasons. And so it's hard for me to just say that it's just related to implicit bias or race. I think that one, healthcare professionals don't know everything. I think that also there are many opportunities in where we can allow for a patient to be maybe referred to someone who might have a better handle on it or put different lens on it. But when we think about research specifically for a Black community, there are instances, so it's maternal mortality, we describe that, and also things such as fibroids, bleeding, endometriosis, which is a pelvic pain condition. And so there are many times, again, going to the pain and I guess severity of the nature of the issue. So for example, from a bleeding standpoint, that patients are somehow dismissed and not heard for what they're experiencing. So that's how things are missed, or I think being able to truly communicate with the patient, one, time given to patients based on what type of insurance they might have or access to care. So there's multiple levels of it. It's not just one thing, but what we do see in research are clearly there is a correlation between race, disparities, and then missed disease condition states, and then leading to poor health outcomes.
Do you think more healthcare professionals of color from different backgrounds would help women of color feel more heard about their cultural concerns?
Yeah, I think even outside of just African American communities and having Black physicians, we've seen that across all minorities, is that when people have the chance to see someone who looks like them, then there's definitely more of a connection, a link, and a trust, I guess you could say, in being able to understand your patient a little bit more, being able from the patient's perspective to be able to feel in a safe space so that they can relay their woes or their issues that they may have, because there's comfort. And even if you were to bring it to a gender level, if we think of OBGYNs in general, historically it was more males, right? And now you'll find that because there are more female OBGYNs, that women actually feel more freedom, if that's the correct word, to disclose some of their issues, because maybe before they really did feel very uncomfortable explaining that to a male. So I think you can see that across anything, whether that's race, gender, or even if you were to bring that to the LGBTQT community, that we've even seen that if they had someone who's more understanding of the connection or their experiences, they're more likely to share.
So, what role can a woman's background or culture play in her access to care, health education, and patient goals?
I think what we have seen, because there was a clear distinction in access to care historically for the Black community, that there wasn't a lot of awareness and education that was brought to these communities. And so through storytelling and experiences, what they shared with their future generations, somehow there was a missing link in the education or the foundational issue of what the issue was in general. So whether it was heart disease, diabetes, that was passed down in a way that there was lack of education. So now what we're seeing is now a generation that does have more access than before is now bringing them up to speed on the education and awareness that comes with certain disease and conditions, in order for them to make the right decisions for their care and take the right steps.
What improvements have you seen in women's healthcare experience resulting from HCP's practice in cultural sensitivity? And what can women do to better help communicate with their providers? How can they push back or lend?
I think advocacy and awareness. So advocacy is always a great place to start, because people then feel that they have, one, the education to speak to the condition, and also self-awareness of what they feel really that they're experiencing, and then taking the time to learn how to communicate that. And then through that, you'll find that through positive communication and from healthcare providers having less implicit bias, that you build more of a trust and support within the communication, therefore leading to more positive outcomes.
Well, what would that look like for the patient, for example? So I'm a Black woman, pregnant. This is my first pregnancy. I go to a white male, let's say, for example, OBGYN. And I say, well, I've been feeling pain in my sides, the sides of my tummy. And it's probably just anxiety or something like that. What does that look like? So what do I do?
Yeah, that's an opportunity for a patient to say, I hear what you're saying. However, I do feel that is not the cause of this. What are some other things that could cause this pain? So now you're putting it back into the provider's hand to give more answers. And then I also say for patients who may feel that, the communication between them and a provider is not adequate, or what they're looking for, that they do have the opportunity to seek advice from another healthcare professional, whether that's in the form of a consult, switching providers, but that can be done as well.
Do you think that cultural sensitivity training should be taught in medical school or offered as a CME? Or do you think that training HCPs would be more beneficial?
I think that cultural sensitivity, from what I know of the curriculum, is a part of the curriculum. I wouldn't say it's necessarily a full course. So I think that there probably should be more time and depth devoted to that topic. I know it is there. I do think it needs to be a little bit more advanced as far as exactly how that can play out, the content, and also the amount of time that's spent with it.
And what steps could HCPs on their own take to facilitate open conversations and help reduce medical bias?
I think that can come in the form of individual time spent with awareness, challenging themselves when they have interactions with people from other cultures or walks of life to continually ask themselves, have I done everything that I can to break any barriers? And then also doing the work to talk to their peers who are from a different race or community of people, to ask them, to be transparent in asking them, what are some things that I could be missing? And how do I do better at accomplishing ABC?
I'm just wondering, because if I'm a provider, let's say, and I don't think I have an issue, I live in a big city, I'm an urban, I see all kinds of patients. I don't think I necessarily have a problem. I feel that I'm very culturally competent. How do I know then that I'm not necessarily? Where would that?
Well, that's actually a pretty easy answer, because everyone does. Everyone does. Doesn't matter where you live, doesn't matter how urban your area is, everybody has implicit bias. So it doesn't, that's the baseline. Everyone has it. So it's a matter of how much do I have, and am I willing to accept that? That's the individual portion of that. Everybody has cultural sensitivity issues. Everybody has implicit bias. So that's a great place to start, because then you can't refute that.
Well said. Well said. Dr. Jessica Shepherd, thank you so much for enlightening and elucidating us today. I really appreciate your time.
Absolutely. Thank you so much.
Thanks for listening to Urban Health Weekly today. I hope you'll join me and my friends next week so you can stay informed and inspired to take control of your health. See you next time.